Hello everybody, my name is Dominik Linz from Maastricht in the Netherlands, and I'm today here with Renate Schnabel from Hamburg in Germany. Hi Renate.
Hello.
So we are here at the ESC 2023 in Amsterdam. It's actually a quite rainy day today, but I think this was perfect for this conference actually. It's a very packed conference, a lot of people are coming inside and actually enjoying this research here. So Renate, atrial fibrillation screening. A lot of people are talking about this. New technologies are now launched, new platforms are actually created. So what is atrial fibrillation screening in 2023 for you?
Yeah, that's a good question. It's wonderful to be here and to discuss this topic, which has come into the focus of our interest over the last years with all these possibilities. So it's not that clear what atrial fibrillation screening is, because we have different ways of screening. We see the old physician or healthcare initiated screening with opportunistic screening. The patient comes into your office, has his or her blood pressure taken, and then you use the opportunity to do a check on the pulse or write an ECG. Today it could be a very quick handheld ECG. Or you do it with a systematic screening, that means at the population base. And this is the STOKE-STOP study that we intensively discussed over the last years since its publication, with more than 20,000 individuals enrolled, screening with a handheld device versus no screening. And there we observed a potential benefit of screening in terms of a composite outcome of stroke, but also in terms of bleeding and cardiovascular death. And there's also increasingly, let's say, patient-initiated or even consumer-initiated screening, something completely different. We have these smartwatches, these small devices that you can wear, many of them not validated, some of them with very good algorithms, and the patient comes in and says, here is my smartwatch, print out, doctor, do something about it. So these are different aspects of screening we need to consider, and actually I cannot tell you what the best way of screening for atrial fibrillation is.
Well, you already mentioned actually those different ways of screening. There are of course also a lot of different devices which are currently used. You already mentioned the wristbands, the smart watches. Several apps are now also available to use this. So do you think that in the future there will be one device, one technology which rules everything, or should we as physicians also really invest time to learn how to look at a PPG, how to look at an ECG and what to do with that?
I think this is going to be mandatory, in particular when patients come in with different devices, with different types of devices, and there are different needs. Older individuals today still may fare better if you do a screening with a handheld device, intermittent ECG screening, or if you want to do very intensive screening, then probably it's better to have a patch device that automatically and continuously monitors over 14 days. With really continuous monitoring over years, like the loop recorders, we had the Danish loop study, we saw that maybe you detect atrial fibrillation, certainly, but the risk reduction for these very short, infrequent episodes of atrial fibrillation is less. So maybe that's not the device of choice for the general population or general practice. And maybe we also need to set into consideration today the NOAA-AFNIT6 results, where implanted cardiac device detected atrial high rate episodes. When they were treated with oral anticoagulation, the risk of stroke was not significantly reduced. So I think we still need to evaluate what the best way of screening is, for whom, in whom, and by which device. And there we'll see an evolvement over time.
Yeah, it's actually interesting that you mentioned now also the NOAA-AFNIT study. So this was not really a screening study, right? But actually it recorded continuously via devices and then also found AF. It's not clinical AF yet, because it's not well symptomatic. It was not recorded by an ECG before. But actually if you treat those, then increased risk of bleeding without actually additional benefit. On the other hand, also the loop study, actually a little bit the same story, not really improvement if you treat those detected by loop recorders. Do you think that there's actually a limited duration of atrial fibrillation which is needed before you actually get this benefit? What I actually mean with this is, if you just record once a day an ECG, you will just find high burden AF. In comparison to this, if you implant a loop recorder, you already find this micro AF, very, very short episodes. So do you think this is critical, high AF burden versus low AF burden?
I think, and this is why I also mentioned the loop study that will be discussed very intensively during this ESC conference, that probably not all atrial fibrillation we find is created equal, and that we probably need to turn towards burden, which means the duration, the frequency of atrial fibrillation episodes, but also maybe the diversity of episodes, how frequent, how often they appear, the density of atrial fibrillation. So we need to learn much more, and therefore for research purposes, certainly more continuous monitoring would be ideal. But for clinical practice, I think we should focus on the high burden atrial fibrillation, which should also be captured with more intermittent devices and intermittent screening strategies.
Yeah. So actually the loop recorder probably one of the gold standard approaches to determine AF burden time spent with atrial fibrillation monitors, right? Also, a loop recorder actually records something like an ECG records an ECG. There are also this PPG, which is actually popping up now. Do you think there's a role of this other technology? The problem actually with this PPG is it cannot diagnose AF. So why should or should not be a technology be used for screening, which actually cannot even diagnose? Why should we do this?
Yeah, it has been shown that there may be a two-step approach if there is no prior diagnosis of atrial fibrillation, but you can record arrhythmic pulse, which PPG, photoplethysmographic detection, can do, and these devices are pretty good in detecting arrhythmias, atrial arrhythmias. Also, we performed a study under the lead of Larissa Fabritz that suggested to individuals aged 65 years or older to wear a wristband device, and afterwards, if there was a notification, then to get a patch device. And this is how also the big studies worked with the Apple Watch study, the Huawei Heart study, Fitbit Heart studies, that if you have a notification and the algorithms of these devices are really getting better and more accurate, then you will also with relatively high accuracy, not 100%, around 80%, 80 to 90%, you will detect atrial fibrillation. So this may be a good way for a first screening. More important, I think those devices are in patients with known atrial fibrillation for the management and treatment of those, or the detection of recurrent atrial fibrillation. So there I see the highest importance of those devices.
Yes, so actually PPG technology as a technology, for example, to find an indication for suspected AF, and then still, of course, an ECG documentation is necessary. But I think one big advantage of the PPG technology is also that it is widely available, right? So every mobile phone can nowadays actually record a very high quality PPG recording. So scalability is quite easy.
Absolutely, yeah. Yes. Which you also have shown with your studies that it's easily available and that can be broadly applied. So there is a place for PPG monitoring.
Yes. But then still confirmation by ECG, of course. Yes. So a lot of studies now available, right? Actually, we also have those big studies. Some of them are positive, some others are not as positive yet as we actually would expect. Do we need other studies, other bigger studies, other consortia? So you are very, very deeply involved in the EFFECT EU consortium. So can you tell us a little bit about this, the role, and why we actually need this?
Yeah. As you said, there is increasing evidence from randomized trials, large randomized trials, but also smaller studies, more than 11 studies that are looking into atrial fibrillation screening that we pull together in EFFECT EU because there is evidence there, but all the separate studies are not strong enough to prove that atrial fibrillation screening has a benefit for the individual in terms of stroke risk reduction, in terms of heart failure reduction, reduction and other outcomes. And so the idea of Affect EU is in a collaborative way with 26 partners in Europe and worldwide to summarize all these data, harmonize them as far as possible, and perform an individual patient or participant data meta-analysis in order to gain the power to have a more definite result. And with many other aspects that we look at, find a refined screening strategy that we can suggest that can be implemented in European populations for atrial fibrillation screening adapted to different healthcare systems.
Yeah, this actually means, so it's actually combining a lot of available ongoing studies, and by this just increasing also the sample number. And I think this is of course always this big limitation of a lot of other studies. A lot of other studies might be underpowered in some way. By combining the different studies, well, that's really a big advantage of this consortium. Yes. The ESC is also playing a role in this consortium, right?
Yeah, ESC has been a partner from the very beginning, from the conceptualization of the project. And ESC's strength is the dissemination. So with their networks, with their experience, we have the ability to perform webinars, which have been very successful because the topic is highly discussed. We have educational courses. We also have sessions. For example, here at the ESC on Monday, we'll have a screening session, lessons learned, where we will discuss such topics. And we benefit from the networks, from the experience from different countries, from different areas of Europe, that all the information is collected here, but also, again, our results disseminated.
Yes. I think research dissemination, news dissemination, this is actually where we profit here also at ESC. A very packed and also very interesting program, which we will see here in the coming days, including also a lot of studies on atrial fibrillation screening, some sessions which you also invented. So this was ESC TV. Renate, thank you very much for this interview.
It was a pleasure.
And enjoy the rest of the conference.